We're going to move now into the next session on misinformation and disinformation, another incredibly interesting and important topic that's moderated by Rachel Pilch-Loeb. So Rachel, the floor is yours. Please take it away. Thank you.
Thank you, Hillary. And welcome, everyone. As Hillary mentioned, I'm Rachel Pilch-Loeb. I'm a researcher and project director with the Emergency Preparedness Research Evaluation and Practice Program at the Harvard T.H. Chan School of Public Health, and I'll be moderating this session. In this session, we'll be discussing mis and disinformation, which communities and groups are more or less vulnerable or susceptible to mis and disinformation, and the strategies that can be used to mitigate the impact of that information. We're going to be building on some of the conversations that you may have heard yesterday about trust in public health science and the public health enterprise, as well as conversations about how different demographic groups engage with the public health enterprise and the trust that is or isn't there. We have a great panel representing a range of different experiences and perspectives. So what I'm going to do is invite each speaker to share their remarks. Each has about 5 minutes to speak, and then we'll continue with a question and answer period. If you'd like to hear more about the panelists or read more about the panelists, a link to their bios has been posted on the event webpage. If you have questions to ask the panel, please put them in the Q&A window beneath the video player. So without further delay, we'll kick it off with Tara Sell.
Hi, can everyone hear me? Yes? Okay, great. I had to switch to phone audio. So thank you so much for having me here to talk today. You can move on to the next slide. You know, we heard yesterday in the first panel that problems with public health trust and mis and disinformation aren't anything new. Here's a picture, a cartoon from the 1930s. So we've seen this for a long time. Next slide. My team also, there we go. My team also did an analysis of mis and disinformation during, you know, the Ebola crisis back in 2016, and you know, we actually saw a range of different things. We saw true information. We saw, you know, stuff that we couldn't tell if it was true or not. But we also saw this distinction here, and I think we heard Brian Castrucci talk about this yesterday, that there's opinion, and then there's stuff that's clearly false. And so we found, you know, about 10% of what we were looking at in our analysis was false there, or partially false. And this is an important distinction here, because sometimes we have content that is partially true, but it's misleading, and it pulls people away from accurate information. So we have kind of two different things going there, and it is really hard then to pull people away from that. Next slide. And so our analysis pushed us to look to the different rumor types. We divided into 4 categories. Many people divide into different ways, but here's how our team does it. We have false cures. We have information that mischaracterizes the disease or protective measure. We have scapegoating, and we have conspiracies. Often those include, you know, an angle on profiteering. There can be a combination of these things. There's definitely ways that you can divide them within this, but we see a bunch of different misinformation rumor types. And so, you know, this is really well reflected in COVID-19, and you can move on to the next slide here. You know, Jeanette earlier today talked about that social milling aspect. And so when we had, you know, everyone move into a stay-at-home order, we had that social milling switch to people doing that on their devices. Next slide. And so, you know, we know that misinformation and problems with trust didn't start with COVID, but I want to sort of emphasize here how costly it has been during COVID. And so our team did an analysis of the cost of mis and disinformation just related to non-vaccination. And you'll see there's a really big uncertainty range here, because you know, it's hard to determine exactly why someone is not getting vaccinated. Is it all about mis and disinformation? But we can still see during, this is not during a surge time. This is during kind of a normal trough. This is related to like June and July time period. There was an estimated $50 to $300 million of cost every day. And this is an incredible amount of money. This means that it is worth it for us to do something about it. And so, you know, if you reduce that non-vaccination that's related to misinformation by just 10%, it would be worth between $5 and $30 million a day. So certainly we need some policies that can do something about this. That brings me to my last slide, or not my last slide, my last topic, and that's we need to have a national strategy here on how we deal with health-related mis and disinformation. And I'm not calling for the government to do everything about this, but that we need to have an organizing structure that figures out how do we bring these stakeholders together. So I have some initial thoughts on that next slide. And that's really, first of all, controlling the misleading content and sources, thinking of it as a national security issue, having a non-governmental task force to guide how we're going to move forward, and have this active and transparent intervention from social media. Not necessarily that Facebook is determining what's true or not, but that they're actually working to control that content. Promoting good and factual information, working with public health. And here, this third pillar, resilience, I think that is really at the heart of what we're talking about today. Increasing trust, increasing that public resilience to mis and disinformation, so that when people are hit by false information or misleading information, they know it for what it is and they can recognize it and move on. And then also just bringing all these stakeholders together, government, civil society, industry, to sort of develop a plan together. So we're not doing whack-a-mole here. If we only solve it in one sector, we're still going to have to deal with it somewhere else. So I'm done even early. I'm ready to move on to the next person.
Thanks so much, Tara. That was fantastic. And it was kind of a great reminder of how this is not just a COVID problem and that we need a kind of cohesive strategy around this. So next we'll head over to John to hear more.
Hi, everyone. Yes, thank you so much. I don't have slides to share, so I'll sort of speak off the cuff a little bit. But I think as Tara explained very well just now, there's a great impetus to reduce misinformation susceptibility. Like a study that we did recently in the UK, basically what we did was we had a sample that was about 22,000 people or something like that, and we had their postcode. So this was not just nationally, but regionally representative of the UK population. And what we did was we looked at whether their susceptibility to misinformation predicted later vaccine uptake in their postcode, and it did. So even if you control for example, voting behavior, political identification, but also things like age and gender and so on, belief in misinformation or how likely someone is to fall for misinformation significantly predicted later actual vaccine uptake at the regional level. So to us, that really means that there's a very clear sort of pressing reason to continue to combat misinformation and reduce misinformation susceptibility, right? Not just tackling the actual sharing of misinformation people do with others, but also how reducing the possibility of someone false misinformation in the first place. But I completely agree with what Tara just explained, that it's not always clear exactly what you define as misinformation, because if you only focus on false content, you miss quite a bit of the stuff that's out there that's, for example, misleading, stripped of context, partially true, partially false. And an example that I wanted to mention is, to my knowledge, it's one of, if not the most shared headline on Facebook of last year, 2021. And it read, from memory, this healthy doctor died 2 weeks after receiving the COVID vaccine. This was by the Chicago Tribune, I believe, published this initially, if I'm not wrong. And the problem is that every single word in that headline is true, right? That did happen. But the implication, namely that the doctor died because he got vaccinated, that's not true, or at least there's no evidence of that. So here you have a big problem, right? Because you're not lying, really, as the headline writer, but you're clearly doing something wrong. I think everyone would agree that the implication that people took away from this headline was a problem. So are you still speaking of misinformation? In a way, yes, but let's assume good intent on the part of this journalist. Let's assume that they didn't want to actually mislead people into thinking that the doctor died because of the vaccine. It was accidental, but nonetheless, it can have tremendous sort of consequences down the line. So that's also why we, like Tara, we focus on sort of the patterns of misleading information or misinformation, so the strategies that sort of underlie it, right? And the way that we try to tackle that is through what's called psychological inoculation. So much like a medical vaccine, right? You vaccinate people by injecting them the weakened version of a particular virus. They develop antibodies against disease. So the same you can really do with information, in the sense that if you preemptively expose someone to a weakened argument or a persuasion strategy, and you preemptively refute that for people, they develop what you might call psychological resistance against future manipulation attempts. That's quite a robust framework from social psychology. It's really old, from the 1960s, and it was initially developed with the goal in mind of, funnily enough, of preventing American soldiers from being brainwashed by the Viet Cong. That didn't really work out, but the framework itself sort of remained and is currently being applied within the context of misinformation. And the way you do that, at least the way we've done that, is in two different ways. One is through games. So, for example, the Bad News online game, or specifically about COVID-19, it's called Go Viral, which is a game that we developed in collaboration with the WHO. And the idea is that you play the game, and in so doing, you learn about the different strategies and techniques that are commonly used to manipulate people. For example, emotionally manipulative language, right? If I, for example, tell a story about a baby that got hurt, had an adverse reaction to a vaccine, right? And I interview the mother, and I make it a whole emotional story, and everyone's crying, etc. I'm not really lying, but I am sort of definitely trying to manipulate people into thinking that vaccines are less safe than they actually are. If you point that out, for example, through a game, it turns out that people actually learn how to recognize these kinds of strategies. Games are one way to do that, and that's quite robust, sort of experimentally speaking. But another way is through short videos, and the advantage of short videos is you can run them as, for example, PSAs or as ads on YouTube or on Twitter and things like that. We recently conducted a study where we ran a couple of short inoculation videos as an ad campaign on YouTube, and that doing so improved misinformation technique recognition by about 5 to 10% on a large sample, which is pretty good considering how noisy that environment is. And within the context of vaccine misinformation, Rachel Pilch-Loeb, who's heads the panel today, she and her team actually developed a couple of these inoculation videos about vaccines. So those are also really useful and a really sort of nice and immediately scalable way to combat misinformation in social media environments. And it works really well, experimentally speaking. So that's quite nice. Thank you all very much for your attention.
Thanks, John. Thanks for both kind of hitting on what is mis and disinformation, how do we measure susceptibility to it, and what are some strategies that your team has tried to combat or reduce vulnerability to that. Next, we're going to go to David.
Yeah, hi. So I'm David Broniatowski. I'm an associate professor at the George Washington University School of Engineering Management and Systems Engineering. It's really an honor to be here on this panel. I first of all want to start out by underlining several of the points made by my colleagues, particularly Dr. Kirksell, regarding the over-focus perhaps on false facts. And, you know, we are here in what has been called an infodemic. The World Health Organization has declared this an infodemic, which they define as an overabundance of information, some accurate and some not, that makes it hard for people to find trustworthy sources and reliable guidance. Nevertheless, a lot of the research and a lot of what we've tried to do in the past as far as correcting it, and even the theme of this panel, in a sense, has been on misinformation, which is largely understood as false facts. And so that may perhaps obfuscate to some degree the multifactorial nature of the problem that we face, which is that there are really multiple actors with multiple agendas that are communicating about vaccines and COVID online. Some of these are state-sponsored, some of these are domestic, some of them are trying to advance particular narratives. And this really touches on one of the points that was made by the prior panel regarding the role of meaning-making, and meaning-making as something that's absolutely key towards addressing how we understand this problem. As academics, we tend to approach the problem of the infodemic from the knowledge deficit model, which sort of suggests that people need more correct information. But if you look at the sorts of strategies that have been used by, if you will, adversaries in this space. So, for example, we did a study on the role of Russian accounts back in 2018 when they communicated about the Disneyland measles outbreak. They actually were equally playing both sides. They were equally likely to talk about the typical sort of anti-vaccine tropes on one hand, but also to make fun of anti-vaxxers on the other hand, and sort of construct this straw man of the person who might be vaccine hesitant. And they did so in an attempt to promote discord, and framing the problem as a misinformation problem tends to sideline that dynamic and the ways in which some of these other actors behave. If you look at some of the ways in which some of the organizations that are committed to promoting vaccine refusal do so, they often frame their narrative in terms of civil rights and bodily autonomy. It's my choice whether or not to get vaccinated, rather than promoting specific false facts. Now, they may use false facts and false narratives as ways of promoting that larger narrative, but it's typically in the service of here are reasons not to get vaccinated, and therefore you should think twice. Therefore, you should have a choice, and you should exercise that choice. And what I rarely see from public health communications is this acknowledgement of, yes, it's your choice. Yes, it's your choice, but here's why it's the right choice. And so in many cases, we actually have possible entrees into counter communication strategies that are actually being offered up by some of these adversarial actors. And we rarely take advantage of those because we tend to focus on correcting falsehoods rather than necessarily addressing the deficit that several of the prior panelists suggested may be some of the main problems here. And in fact, this is supported by a recent study that we did where we found that looking at a very large number, hundreds of millions of social media posts on Facebook and Twitter pertaining to the pandemic, we found that the majority of these actually linked to high credibility sources, where credibility tends to be a proxy for misinformation. And even among the lowest credibility sources, to Dr. Rosenbeek's prior point, more than 3/4 of those posts were not explicitly false. Rather, they were misleading in some other way. They were decontextualized, but they filled that meaning deficit. They addressed this sort of need for a rationale to explain the infodemic, which is to say a sudden huge surge in uncertainty and overwhelming amount of information. So where does this leave us? Well, people are inundated with information, and when inundated with information, we need to give them insight. And we actually have theoretically motivated approaches. There's a theory called fuzzy trace theory that specifically emphasizes the ways in which you can construct messages to communicate a bottom line meaning, to focus on that meaning deficit. And so I'm gonna sort of stop here and say that addressing the spread of misinformation during the infodemic is something that has to address the wider context in which that misinformation is embedded, and specifically the ways in which misinformation is leveraged in service of a larger agenda, which is to construct a set of meanings that serve the purposes of the actors online.
Thanks so much, David. I think that that's really valuable context for us to not just be thinking about this information in isolation. Over to Wilma now.
Good morning. So thank you, Rachel, and good morning. I am Wilma Wooten, Dr. Wilma Wooten. I'm the Public Health Officer for the County of San Diego. I want to thank you for the opportunity to speak with you today about how our county has addressed misinformation. So responding to COVID-19 pandemic has indeed been challenging for everyone. San Diego County has utilized numerous approaches in our response. We landed on 7 key strategic approaches utilized in response to the pandemic, and starting with standing up an incident command system, which I heard someone mention earlier. Today's focus, however, will concentrate on communication, which is circled, as a strategy to address misinformation, and also includes the strategic approach of sector partnership, as well as, which I will describe later on in my talk. So the problem of misinformation, disinformation, and malinformation has been pervasive throughout this pandemic, but became even more prevalent last year. So many claims are consistently made that are not substantiated by evidence-based research or facts. Early on during the pandemic, our county stood up a COVID-19 website, specifically with a section addressing misinformation issues as they occurred, and focusing on specific claims and providing the actual facts about the issue. With the claims becoming more prevalent, health misinformation was declared as a public health crisis on August 31st of last year by our county Board of Supervisors. The resolution followed guidance from the U.S. Surgeons General's advisory confronting health misinformation for building a healthy information environment. Now, taking the lead from recommendations in the Surgeon General's advisory, the County of San Diego Board of Supervisors resolution called for 7 strategies to address misinformation as a public health crisis. Strategy 1 called for resources to provide timely information to combat misinformation. This was done through messaging to reach all communities, and expanding the county website to create a space to help the public obtain timely, accurate, and reliable information from credible sources. The website provides guidance on how to find credible sources of information, COVID-19 claims and facts, and frequently asked questions from emails, sector briefings, and other communications to the county. Strategy 2 focused on community engagement to share timely and accurate information. And this was done by hosting town hall meetings and forums with high-risk populations, conducting academic detailing with our healthcare providers, especially those that are in the lowest health quartile zip codes, sharing information on social media, and training trusted community spokespersons. Strategy 3 focused on research efforts by conducting a public survey every 6 months and utilizing that information to implement public education campaigns to counter vaccine hesitancy, address community concerns, and address misinformation. Strategy 4 focused on training the healthcare sector by partnering with community practitioners, our professional healthcare associations, and the healthcare hospital and clinic systems. Strategy 5 focused on our local government, partnering with all of the sectors, and this was one of the strategies referenced at the top of this presentation, focused on leveraging Live Well San Diego partners, which include governments, schools, businesses, and faith and community-based organizations. And those 4 sectors were expanded to over 20 sectors to reach the community and get feedback from the community as needed. Strategy 6 focused on identifying resource gaps and working with state and federal partners to dispel information. And lastly, while Strategy 7 was initially focused on partnering with our local medical community to develop a standalone website focused on misinformation, this strategy was modified, and instead we developed a medical panel, and it was convened monthly the day after our Board of Supervisors COVID-19 update. Medical experts were convened to review and comment on some of the misleading claims that were circulating in our community, and a video of all of these monthly forums are posted on our county's website. So thank you again for the opportunity to briefly share San Diego County's communication approach to address misinformation. Thanks.
Thanks so much, Wilma. I think that was a fantastic example, kind of illustrating the way in which to approach the context and combat this problem. Over to Mike now for the last presentation.
First of all, thank you, Rachel, very much for having me and the opportunity to be here. Let me preface my comments with two general concepts, you might say. Number one is I approach this issue with a great deal of humility because I think I know less about it than I did 2 years ago. And I think this is something we all need to consider as we walk through what we know and don't know about COVID, information sharing, where does misinformation or disinformation come from? More importantly, even what is misinformation and disinformation? The second thing I would preface my comments by is I'm reminded often of a statement by Lewis Carroll that if you don't know where you're going, any road will get you there. And I think that far too often we have been on that road. You know, the old idea is Yogi Bear, if you come to a fork in the road, take it. So let me preface my comments in that regard. First of all, when we talk about misinformation and disinformation, one of the things we're often missing is time. Time is a critical element here because what was thought to be scientifically sound information 1 year ago or 2 years ago is not today. Is that misinformation then in terms of what happened or how it changed and how do we communicate that? I would suggest that today the most important issue in how people consider information is where does it come from? Who do they trust? And if we in the public health community, which have had almost a constant evolving message, some almost highly contradictory messages, how do people interpret that? Do they trust us? Why would they? Evolving science in itself has not been something we've really talked about. Let me give you some examples. When we had the first data coming forward with regard to the vaccines, the mRNA vaccines in particular, we shouted from the top of the buildings that we got 90 to 95% protection. You led people to believe that after 2 doses, we were kind of going to be out of the woods. It was a year ago right now that we had many of our talking heads in the science world out there saying, look, we're down from this January peak, cases are coming down, so many people are immune, and we have these highly effective vaccines. We're not going to see much activity probably until next winter, and then hopefully limited. Well, that turned out not to be the case at all. In fact, we've realized over time that the mRNA vaccines are challenged with waning immunity, just as recently as yesterday. We'll talk about that in a moment. And the fact of the matter is now people are asking, wait a minute, you told me I needed 2 doses. Now you're saying I needed 3 doses. Wait, you mean I need 4 doses? And we have not understood that very evolving science issue has left a lot of people feeling a lack of trust in what we say and how we do it because we've not explained the story of where we've been, where we're at, and where we're going and the concept of evolving science. Shortly after the J&J vaccine was approved, everyone jumped on board. It was a 1-dose vaccine. Yeah, you're right. It wasn't quite as good as the mRNA vaccines, as opposed to 95% protection. Maybe you got 80% protection. And then over time, even that came into question. In the last 3 weeks, we have now seen studies clearly demonstrating the J&J vaccine may be the superior vaccine because unlike the mRNA vaccines, it doesn't wane in immunity. And that at 6 months out, the protection is actually higher from 2 doses of J&J, and it's consistent than it is the mRNA vaccines. Now, how do we change that messaging in such a way that people actually trust us because we are explaining to them how we got here? Instead, what they hear is a message of confusion. They don't know what to believe. Probably the very highlight of this has been the issue of masking. Let me just say right up front, I have not been a big supporter of mask mandates. Why? Because the vast majority of people who are masking are using cloth coverings or surgical masks. And the data now are compelling. For those studies that have shown that surgical masks have some benefit against an aerosol, they had serious study design issues and flaws. The data are compelling right now on aerosol-related transmission, and N95s are really required. If we could get people to do that, then we could have a very different perspective on mask mandates. But we in public health, CDC has been one of the leaders in misinformation on respiratory protection, such that even the White House this past week put out a blog from the Office of Science and Technology basically clarifying that issue. We ourselves haven't gotten our act together, so how can we basically arbitrate or try to provide more clarifying information to the public on masks when we ourselves have been a source of the great deal of misinformation about that? So I think that one of the issues that we have to look at is how do we as public health and the science world address this? Take no further than yesterday. 4th dose has now been approved. I will be the first to tell you that waning immunity is a real challenge with mRNA vaccines. I said that last August about the 3rd dose mRNA vaccine. A 4th dose is clear and compelling, I think, relative to what information we have. And clearly, it is incomplete. But we have new data out of Israel as recently as last week. Last night, we had people, talking heads on television, saying there are no data to support that a 4th dose is necessary. Yet there's others who will say, yes, absolutely this. And so the point being is that, in fact, the public is feeling confused by our misinformation. So let me just conclude by saying, I think at this point, we have to look at ourselves and we have to look at time. And we have to understand, how do we clarify messages? How do we serve as the science basis so that we can then judge what is misinformation and disinformation? And I don't think we in public health have our house in order. And I think that's one of the real challenges that we face today in terms of credibility going forward.
Thanks so much, Mike, for kind of rounding out the initial comments from the panel. I think we had a really nice continuum of comments, kind of ranging from the context of mis and disinformation or the information environment and how it's influenced prior events and what the cost of it is kind of at this point in time. Some strategies that have been tried more generally to think about how can we address the misinformation and reduce vulnerability to it regardless of topic or when things are topic agnostic. To think about the information context and how we cannot just look at pieces of information in isolation. To think about some strategies that were actually applied in working to address a given context in San Diego from Wilma. And then to think about the role of public health communicators and in not necessarily owning the uncertainty and changing science that we have kind of proclaimed and talked about. So I think that there's a lot of questions that have come in. And I think that just to kick us off, kind of, many of these presentations have hit on the current topic of COVID-19, but we know that this is going to be an ongoing challenge, whether it's related to COVID and vaccination, or it's related to pick your topic du jour. So can each of the panelists perhaps think about how you see this playing out in future public health emergencies and what we can be doing to try and address that as we move forward? Would anybody like to go first?
I'll start.
Thank you.
I'll kick it off just because I titled my presentation the Mis and Disinformation, the now and future problem.
Perfect.
I 100% agree. This is not just, I think people just have realized it, with COVID, but that this is going to be a problem going forward, and people need to be prepared for it. I think that we have many steps to make, starting with a national strategy. But, we could go further. We could think about, can we forecast this? Can we do a national weather center basically for this? Can we think ahead about what we're going to see? What we can expect to see? Some of these messages that we see are unique, but many of them are not. We should have expected to see infertility risks. We can probably expect to see autism rumors in the next few weeks as we see the under 5s get their vaccine authorization. So, I think that we shouldn't be caught by surprise here. This is something that we're going to see, and we can expect to see, both unique, but also this copy and paste version of mis and disinformation as well.
Thank you, Tara. John?
Yeah, I completely agree. I think a lot of misinformation is basically predictable, or at least tropes. For example, around elections, that there's going to be accusations of election fraud. It's just a feature of it. We know that this will happen. It's very unlikely that they're true. Might as well get prepared. So pre-bunk, right? Preemptively debunk rather than debunk. Or do both. It's not that debunking is bad. But I also agree completely with Dr. Osterholm that there's a need for looking inward a little bit. And we recently did a couple of experiments looking at whether communicating uncertainty affects issue perception, right? So, for example, if you communicate to people that you don't know certain things, that you sort of illustrate, well, these are the error margins that we have about the efficacy of vaccines, let's say, Does that backfire? The answer is no. In fact, it's actually beneficial, especially for people who are already sort of a bit more on the fence about vaccines. So for people who are already very pro-vaccine, it doesn't make a difference what we tell them because they're already pro-vaccine and the communication doesn't affect their attitudes. But people who are more sort of doubtful about how well vaccines work, turns out that communicating this uncertainty is actually beneficial. So I would certainly argue in favor of doing that, even if it feels a bit scary, right? It feels a bit like, well, if we tell people that we don't really know something, and will they just sort of step back and think, well, nobody knows? The answer is probably not, because if, let's say, the CDC doesn't tell them, someone else will, right? So might as well.
Thanks, John. Wilma, do you have a comment?
Yeah, I agree with everything that's been said. I just think there are a lot of lessons to be learned from this pandemic. Being transparent, and I often say when we have a crisis, you tell people what you know, you tell them what you don't know, and you'll get back to them with additional information as it comes available. And just being preemptive, so that we can dispel myths, I think is or claims is very important. Being proactive but you can't address everything because there's so many claims and myths that are showing up, but try to address the ones that may have the most impact to the community. So again, taking the lessons learned from this pandemic can certainly be effective in other public health threats as well.
Thank you, Wilma. David?
So I would just add that we're at a point now where there are opportunities to look at what has worked and specifically what has worked for those who are communicating misinformation and to ask ourselves why it's so successful. And one of the things that we frequently see from the rather small number of highly successful organizations that promote some of these falsehoods is that, first of all, they're highly organized. Second of all, they are expert at using social media to reach individuals. And that's something that we have not really focused on. We focus more on broadcast. We focus on getting the message out, but we don't focus on what happens, how that message lands, and then following through as much. We certainly have we certainly have a lot of good experience with communicating face to face, but what I see less often is people whose job it is to interact in online spaces with people who have questions as the misinformation is coming in. And so I think that building up that competency will serve us well in the future, and is something that we're not really investing in right now.
Mike, go ahead.
Yeah. Well, I think that, first of all, what we have to understand is that this is not all about mis and disinformation. We have to acknowledge another big black hole that we don't understand. Let me give you a case in point. We've tried to look at those individuals who have received 2 doses of vaccine in the United States. They were not vaccine hesitant. They were not vaccine hostile, but they have not gotten their 3rd dose, which the data are clear and compelling now, how important that is. So think about that. 55% of people who had 2 doses have yet not gotten a 3rd dose, despite the very strong recommendations. When we talk to them, we try to understand why. It's not about disinformation or misinformation. They're just done. They decided this is all I'm going to do. And I don't think we really understand what happens with time. If you go back to the 1918 influenza pandemic, and I grant you it was a very different time in the world in terms of information dissemination, but by 1920, where the surges, or in some cases as severe as they were in 1918, people checked out. They did nothing. They refused to comply. Even look at what's happening right now in the United States. Public health did not lead the way in opening back up again. It was the governors. They made the decision to open up long before any public health measure indication came out and said, you can come back to somewhat of your pre-pandemic life. They were reading the tea leaves. We will never again get the public in the United States around this pandemic to take down extreme measures. They won't do it. We don't understand that. That is not mis or disinformation. That's human behavior that has been formed through ways that we don't understand. And I think that is the part that is as important as the disinformation. And I know disinformation. I've been on Joe Rogan twice to try to hit that head on. Talk about trying to plant your petunias in a Category 5 hurricane. I did it. I tried. Okay. And so I understand the challenge there, but this is not that. And we have to distinguish these. Why do those 55% of people who have been vaccinated twice refuse to get a third dose? That's kind of, in a sense, an example of, I think, what else we're up against that we're not addressing right now as public health practitioners.
Thank you, Mike. That's an important.
Rachel, can I just?
Yeah, absolutely.
Can I elevate something that Mike just said? So Monica Schatzbaum is on this in this audience as well, and so I credit her with this important point that she's been making for a long time. But Mike just mentioned it's about what people do, right? And it's not just can we create a techno solution? Can we create a countermeasure and then people will automatically take it, right? This is also a social behavioral problem, a social behavior consideration that we need to be thinking about. So it's not just about creating a vaccine in 100 days. It's about creating a vaccine that people will take. And we need to do that social behavioral research, understanding the parts of mis and disinformation, but also just how people behave, and incorporate that into our planning, which I think is really missing right now.
Thank you, Tara. I briefly want to hit on kind of a component of what we heard from John, and kind of this notion of very specific strategies to counter disinformation, or maybe counter specifically not the right word, because there's this distinction between something called debunking misinformation, so addressing head on what you've heard, and what pre-bunking, or what John kind of referred to as inoculation-based messaging. And I think that there's some questions from the audience of what's the evidence that kind of to support a given strategy to address misinformation, and how can we feel confident that pre-bunking or inoculation messaging around something like vaccines is ethical? If we don't feel like it's ethical to promote misinformation about vaccination, should we really be kind of trying to manipulate or persuade people to have a given vaccine belief before they've heard something negative? So John, perhaps you can start, and then if anybody else wants to comment, thinking through these two distinct strategies to counter misinformation and saying a little bit more about inoculation's use in this context.
Yeah, sure. Thank you, Rachel. Yeah, so the the point of inoculation treatments and pre-bunking isn't necessarily to persuade; it's rather to prevent persuasion from happening, like unwanted persuasion, basically. So, in a sense, it's basically increasing resilience against sort of manipulation attempts. So, in a way, you're only sort of pointing out, so without pointing fingers, which I think is very important because that engenders a backfiring effect very likely. You're pointing out some of the ways in which it might be commonly sort of misled online, for example, the emotional manipulation strategy that I mentioned earlier, right? To warn people against those. And experimentally, what that does is just sort of the warning and the refutation element combined makes people less likely to find this type of misinformation reliable, right? And so it also makes them, at least in self-reported measures, less likely to share it. And these effects hold up however you measure them, and also they seem to exist in real-world sort of social media environments. So there's a decent amount of sort of experimental evidence that you can reduce susceptibility to misinformation using these measures, again, without really making a claim of fact. That's kind of the nice thing about it, I would say, that you don't really tell people this is true, this is false. Rather, if you encounter something that looks like this, you might be manipulated, right? Do with that information what you will, that's completely up to you. But it turns out that most people actually consider that information to be far less reliable, which is kind of what we want to achieve. Yeah.
Yeah, thanks, John. I think that that's super helpful. And I think it's, from my perspective, at least my own work on kind of the use of inoculation theory or the application of it in this context, is that it's a way to, in some ways, teach critical thinking about the countering information. So how do you kind of approach a piece of information when you see it? I don't know if anybody else on the panel would like to comment on specific techniques or strategies that practitioners or the public should be thinking about when they encounter information to decrease perhaps the influence of mis and disinformation?
Can I just come back? Because again, I think we're running this road here of what is mis and disinformation. Let me give you two very different counterpoints that I think share one common theme. What's happening right now with vaccines and cases? The vast majority of the American public, for that matter, of the world, would say COVID's not that big of a deal. Most of us had mild colds. We had, whatever. And they don't understand yet the impact that this has had on hospitalization, serious illness, and deaths. And we don't have a vaccine anymore to prevent infection. That's not what these are. These are to prevent serious illness, in basically hospitalization and death. Right now in Europe, they are seeing in a number of countries the highest incidence of COVID they've seen since the beginning of the pandemic. Yet hospitalization rates are much lower. Well, we haven't evolved that story yet with us to basically shared with them. This is a vaccine that will basically, hopefully, keep you from dying and hopefully keep you out of the hospital. Well, how many on this screen think they're going to die tomorrow? Not very many, okay? And so therefore, most people don't respond to that message because they don't believe it's going to happen to them anyway. Now, the counterpoint are those 7.2 million Americans and throughout the world who are immune suppressed. They think they are going to die tomorrow because of COVID, and they could easily have that happen. And so now that message is totally different of how do we protect them who are highly vulnerable, and what does that mean? And so I think part of our challenge is that's not disinformation or misinformation to the public that doesn't think they're going to die tomorrow, yet that's the message that these vaccines are incredibly important in reducing that, to the message to the chronically ill / immune compromised that think they are going to die tomorrow. And these vaccines can only do so much for you. So what else can we do? And I think we have to start slicing and dicing these issues before we can really even understand what does dis or misinformation do to that piece? What does it do to this piece? And I think that's to me still a huge challenge that we have.
Thank you,
You mind
Mike.
if I jump in real quick?
Absolutely. Nope, please go ahead, David.
Okay, so actually, I think that Dr. Osterholm's comment really touches on this idea of gist, and what it really emphasizes is the role of communicating the bottom line meaning to the person who's listening, which means understanding their personal context. Mm-hmm. And I cannot agree more that, for some people, there's really this sort of perception of vaccination as being the difference between life and death. And then for other people, their perception is exactly as Dr. Osterholm said, well, I'll avoid a cold. And one of the things that we can do as communicators is we can help to communicate what are the risks involved in a way that really sort of drives the point home that, yes, it's true for the vast majority of people that it's just a cold. However, you may end up with long haul symptoms that make you sick for the next several months. You may end up in the ICU where you're on death watch because at any point in time, you may lose the ability to breathe on your own and you're hooked up to a machine, right? These are the sorts of things where, communicating not just the probabilities, but the categorical possibilities, which is to say, it's not about the numbers, it's about what could happen if you don't take this protective action, is something that I think a lot of people don't make that connection. When they see all of their friends who have had COVID essentially had a cold, then they may not necessarily draw the conclusion, which is scientifically supported, that there is a possibility, even however small, that they may end up in that worst case scenario situation. And we have to help them to understand what are the circumstances under which that worst case scenario should be avoided.
Yeah, I'm going to jump in as well. Rachel, just to point out, we have to meet people where they are and understand what moves or what activates them or to action. And I think I look at this, the whole conveying the smoking message. I look at it from that perspective. Number one, you're not going to change everyone's mind, but you can provide information to those people that need additional information to make a decision. And as was stated earlier, the individuals that have been vaccinated, those individuals are great, but if they haven't gotten their booster, that's another topic or issue that we have to meet them where they are and find out, well, why? So I think it's very important. And that's the surveys that we've implemented about every 6 months. We take that information and we try to craft messaging that is directed to the various populations and attitudes, knowledge, attitudes, and behaviors based on the results we get from our survey. So we utilize that information to craft our public education campaigns. And I think that is why we are successful at having over almost 83% of individuals that are eligible in San Diego fully vaccinated.
Thank you, Wilma. That's a really valuable addition. I think what's fascinating about where this conversation has gone at the moment is we're talking about context at two different levels. One, the information context, the actors at play spreading information, the way in which public health scientists and government officials play a role in that environment. And then we're talking about the context that people operate in, human behavior, and how those two things come together in this very dense information environment at the moment. What's challenging about that, and shifting gears a little bit, is whose responsibility is it to think about addressing this environment? So I wonder, perhaps Wilma, we can start with you, but how does addressing, I'll call it the information environment because I don't want to just call it mis and disinformation. How does addressing that fit in with public health's existing responsibilities at the local, state, or federal level? Is it a distinct activity, or is it kind of already part and parcel with what you're doing? And then if others would like to comment, please go ahead. Wilma, I think you're on mute.
It is part of communication is a core component of public health. But as was stated earlier, there's work that we need to do. And the message comes from the top, from CDC. And sometimes the information was confusing, or people thought it was confusing. Let me just say that. And so state and local jurisdictions then have to modify or craft the messaging that fits with just the overall culture in their various jurisdictions. So it is certainly a role of public health. I think it's a key role of public health, but everyone has a role. Practitioners have a role. All of the various sectors I mentioned, everyone has a role in communicating information so that everyone is adequately informed. And it's public health's role to communicate that information, to provide tools so that the various sectors can then push it down to their populations.
So, one thing that we've found in our research when we've been talking to public health communicators, a lot of times we're interviewing them and they say, it's just me doing all this work. And I think that a lot of times when people in the policy world or leaders say, I know how to communicate, how is communication such a big deal? Why do we need to fund it? It's such an important thing. And I just think, it has been often sort of like the stepchild of public health that we don't fund public health communication the way that we should. It's at the level of importance that it really is, because we can make this great vaccine, but if no one will take it, it is not worth it.
Exactly.
Or it's not working. And so, I think that we need to sort of emphasize that funding public health communication is a big priority and needs to be funded at a much better level than it has been recently.
May I add something?
Yes.
So one of the things that I think the UK government did very well, I live in the UK, is right at the start of the vaccine rollout, they contacted basically local institutions that enjoy a lot of trust in certain communities, for example, mosques and temples. And they basically involved them in the vaccination campaign. Mm-hmm. And I thought that was a very, very good idea, in the sense that you're sort of stepping out of the way as, in this case, it was the National Health Service, and especially the central government, Boris Johnson and so on, and said, look, we don't want to sort of necessarily take credit for this vaccination campaign. What we want is for as many people to get vaccinated as possible. And to do that, we need help from local sort of trusted actors and institutions. And that's also something to keep in mind, I suppose, that sometimes it's not feasible to overcome a certain level of distrust, right? And so who can you involve that does enjoy a lot of trust in certain communities? That's something we're thinking about.
I would just add to that, sorry, very briefly. I would just add to that, it's precisely those people who are best positioned to understand what are the messages, what are the contexts that will be most compelling to their audiences.
I just wanted to add that that's exactly what we did in San Diego. We utilize faith-based organizations. We also utilize what we call in San Diego promotoras, or community health workers, to go out into the community. These were trusted messengers, if you will, but we also looked at healthcare providers that were trusted messengers in their communities. So there's no one size fits all. You have to utilize all of the various strategies that are available to you to reach all of the different attitudes, behaviors, and beliefs that are out there about COVID-19, and particularly testing and vaccinations.
Rachel, could I just add, I think that what's really an important point here is that we do have to meet people where they're at. And I think we far too often focus on the extreme disinformation, which is clearly in a group of individuals for which, we are never going to change their mind. Remember, there's actually a society in the United States of flat earth believing people that meet every year. That isn't something you're going to change overnight, okay? But there's that large group that can be heavily influenced by having a trusted source of information that is willing to acknowledge what they know and what they don't know, and how things change over time. And I think one of the examples we have, and I think, John, you hit on this, but I really want to back this up. Dr. Stephen Thomas, who's at the University of Maryland, who I think runs one of the most amazing programs in the country on the Black barbers, Black beauticians, where they have an outreach source there of very trusted individuals. And what they do is they keep them educated about the current issues. And so when the individual is in that chair, they get it from a trusted source, but also current, somebody who knows what's happening right now. And I think that's the group we can really have an influence on, where it's not disinformation, it's not misinformation. They just want to know, tell me something that I can believe and trust. And I think we do it in disservice by trying to lump that all together. We need to separate those out. And where there's a lot of potential low-hanging fruit is in that group that I just talked about, and people like Dr. Thomas and others are really trying to address.
And thank you for referencing Dr. Thomas. He was a participant on one of our panels yesterday. We have just about 3 minutes left before we transition to our next panel. So I guess as a final question, some have suggested that a lot of this connects to information literacy or digital literacy among the population. I wonder if any of you have thoughts on how we can increase information or digital literacy among the adult population in the U.S. John, go ahead.
Yeah, so the games that we made, for example, are basically trying to do that in an indirect sense, I suppose. So let's acknowledge that most adults don't want to go back to school, and a lot of people aren't exactly interested in taking a media literacy class, which I think is fair enough. So I think it's very useful to think about creative ways to get certain information to people, and one of those is by making it entertaining. And I think also Dr. Osterholm did this very well when he went on Joe Rogan, basically providing sort of accurate information to a group of people that is very much willing to listen to experts, let's say, especially when they're interviewed by someone like Joe Rogan, but aren't necessarily always reached by experts in that sense. So those I think are two ways that are really really useful and really beneficial.
Yeah, I do really like the work that John does, that to push people to sort of recognize that they're being manipulated. And I think that's really one of the most important thing here. But I also want to call out something you said, Rachel, that, we're educating the adult population. The solution to this is not just to have a high school class to teach, high schoolers how to do this. I mean, I think it is across the age range. And, particularly many older adults have a hard time, figuring out how to parse the information that they receive in their emails or on social media. And so I think that, these solutions need to sort of run the age range. But what they are, I think that this is still a new and emerging area of science, and I think that we have a lot more to learn there.
Thank you. Before we conclude, would anyone of our panelists have anything else they'd like to add? Hearing none. I just want to thank all of our excellent panelists for contributing to the conversation today. It was wonderful to have all of you participating.